Hi, as you know, I'm Russ Glasgow, and I'm afraid you're stuck with me for this course in terms of going over our topic for this session. We have a combination of two issues today. One, pragmatic research, and second, costing or economic issues in writing a D&I grant. These are separate but related issues, and ones that we feel are really important, both to do well in terms of grant review, but maybe even more importantly, to really increase your chances of having a successful project and to have an equitable, impactful, and sustainable project after you are funded. So let's get started. Again, just a little more detail on what we want to cover and we'll be discussing. The first one has to do with pragmatic research, its definition, some examples, and then in particular, we want to go through a system to show how pragmatic your research is in different ways, your research design. Then we're going to switch gears and talk a little bit about costing, health economic issues, and especially focus on reporting time and cost in D&I research. In each section, I'll conclude with a few bullet points. Again, we can discuss in class, but a few key bullet points for our advice about particularly how to handle these in your grant proposals. Let's begin by just talking a bit about what pragmatic research is, and I hope you've had a chance to read some of the articles for the course. But for explanation, the approach we're going to use for pragmatism is based on some work that's been done in the UK in particular and Canada, and they have slightly different terminology than we do. And they like to contrast, and I think that works for us here too, what they call an explanatory in UK terms, or in our terms, an efficacy trial, with a pragmatic trial. And this is usually seen in an intervention trial, most often in a randomized control trial, but it doesn't have to be. It doesn't have to be a trial at all, and it can just be research in general. But the overall notion is that an efficacy study is done under ideal conditions where the investigator controls a whole lot of things. It's a very selective, specialized population, specialized setting, often specialized agents, contrasted to a more real-world test in a real-world population under close to, quote, usual care conditions. We'll come back to that. In efficacy trials, usually focus on maximizing internal validity, whereas pragmatic trials tend to emphasize external validity or generalizability across the dimensions that are seen here. So some of the key differences, just drilling down a little bit more on the next two slides, are shown in this table, which contrast if you will, a traditional or more efficacy RCT, or often you can think about these, a lot of drug trials are what's driven kind of the conceptualization, even within D&I trials or research. Those are in that center column. And then in the right-hand column is a pragmatic clinical trial in this case, although think of this more generally. Again, it doesn't have to be an RCT. But as you can see here, I won't read all of the details, but that the overall purpose of these types of studies are different. Where a traditional, more efficacy trial, the goal is to determine causes and effects. We'll have a discussion about causality, if that's really possible to do in most studies. And that is in contrast to a more pragmatic focus, which is concerned about real-world application issues. And that would be to inform clinical, and we also should say that they're public or community health or policy decisions. The next slide shows a few other differences that we'll get down to, including the measures that are used. In a more traditional health services trial, we want to focus on getting the best measurement we can, the most validated measures that'll give you the most precise results. And again, under the most controlled conditions. Often, not always, but often this type of data collection ends up being very costly, sometimes needing to have experts do it, and then either scoring or analyzing it is a fairly major undertaking. And you may or may not share the results with stakeholders involved in the trial. In contrast, the pragmatic trial really emphasizes brief, still validated and good reliable measures, but ones that are brief, that make sense to stakeholders, that can be easily collected with low burdens in real world usual care settings, be they clinical or community settings. So one other way that I like to think about pragmatic trials compared to a more traditional health services resource is to think about the kind of funnel, how much funneling is involved. And these issues apply to, they're easiest to maybe understand in terms of participants, but the same issues apply to staff and the settings that are selected. So on the left-hand side, you can see a traditional trial, if you will, which is, again, you select for a highly specific and generally a homogeneous population. What you want to get is homogeneity so that you can minimize the variance you have. So if you will, and think in terms of a funnel, in terms of the whole population, okay, that's out there, often a traditional efficacy trial has a lot of exclusion criteria. A classic one in the health area is, let's say you're studying diabetes. Well, to do that, to get the cleanest estimate, you probably want to eliminate people that have advanced cardiovascular disease, that may have cancer, that may have osteoarthritis, a bunch of issues that may have some mental or behavioral health issues. And the reason why is to get the least confounded assessment of diabetes. And so what you end up with at the bottom is there's a lot of narrowing of the funnel, but you get a cleaner efficacy study to address the specific primary hypothesis. Let's go to the right-hand side. A more pragmatic approach, research approach, includes a much broader percentage of the population. This probably should be modified. There is some winnowing. Like, for example, you probably don't want to include patients who have high levels of dementia or that are undergoing palliative care and hospice or something like that. But in general, you want to be as broad as you can because the focus is on generalization to real world populations there. And again, a note that this applies, I talked about at the patient level, but this also, the same issue applies to the staff. How many requirements or exclusions do you have on what types of staff that can apply, their level of training or expertise, and the same thing with settings that are involved there. Do you kind of take all comers, or do you take settings that are only highly experienced, highly motivated, that have a fairly high level of resources, things like can give you good electronic health record data. So in terms of reporting, we like to recommend considering a what's called the PRECIS tool for planning and reporting. They're called the Pragmatic-Explanatory Continuum Indicator Summary. So because that's such a mouthful, we usually refer to it as PRECIS here. And its goal is to help you think about how pragmatic is your study. I want to make a note that so far, I've been, for explanatory purposes, kind of presenting these as polar opposites or dichotomies. In the real world, though, there's probably no study that's been completely pragmatic or completely efficacy, but you make some decisions a priori and thoughtfully about what are the issues or the dimensions on which you want to be more pragmatic or more efficacious. So I do want to emphasize that although the PRECIS tool, and in your readings that you have there, probably the Loudon one at the bottom, has focused on use in planning, and that's critically important. This also has been used successfully for reporting results and in grant proposals and reporting in publications too, as illustrated in the Gaglio publication there. So here's the classic PRECIS wheel, if you will, that has 9 dimensions. And we'll talk about a few of these, but you can see these are various important aspects of a trial design. I gave you examples of kind of eligibility and recruitment and maybe the settings that are involved, but it also has issues to do in particular, like at the bottom, in terms of the flexibility of the design that you have. And these are things like the flexibility of the design has to do with who kind of is selected to do it and how much, if you will, kind of control or protocolized is this. On the left-hand side, the flexibility adherence there refers more to the patient level. And that again is, do you just kind of only monitor and provide feedback to patients or a prompt, if you would, as would be done in usual care? Or do you really want to assess, because of a study, to make sure that the intervention or a program was implemented as you intended? So there's a fair amount of monitoring there. You can go around and read the rest of the 9 dimensions, but these are 9 key aspects of research design in a study. And again, this one is specific to a clinical trial. We can discuss potential applying it to other areas. And again, on each of these 9 dimensions, the way PRECIS works, if you give it a score using an integer value from 1 to 5, and if, let's just take an example of a setting. If a setting was one that was highly efficacious, where you really excluded the vast majority and you only wanted settings that saw a very large number, let's say, of PTSD or autistic cases, and you only wanted specialty centers that were done, and you only wanted really experienced clinicians that were implementing a fairly complex intervention, you might give it a 1 or at least a 2. On the other hand, if you really wanted to generalize as much as possible and were including all sorts of usual care practices out there, you might give it a 4 or maybe even a 5. So let's take a look at what this looks like in one of the, first we're going to talk about a little bit more definitions here about what do these things mean. And again, I've just presented here the first 3 dimensions. But the question that you always ask yourself is the extent to which this looks like what would be done in usual care. So again, for eligibility, the question is, are the participants in this trial, how similar or different are they to those who would receive a program if it was done in usual care? And again, you get a 5 for most pragmatic if the population here, or the sample, is identical to what you'd see in usual care, almost all comers. And you would give it a 1 if, like the example I gave, there were a lot of exclusions, again, to maximize internal validity. I won't read the next 2, but again, the notion here is how similar or different is this to usual care? That's always the question you ask yourself for each of the nine dimensions. So here's what I thought we were going to have before, what we call the PRECIS diagram that you can use. And I'm a big fan of this, I have to admit, I'm biased, but the notion and the really nice thing about this is in a concise little figure here, after you've had a little experience with using the PRECIS, understanding the model or the framework, you connect the dots essentially here, and you can see the level to which a study is pragmatic or more efficacy or explanatory study, and importantly, not just that overall, but you can see the dimensions and how it's more versus less pragmatic. So on this one, the green, the study in green, is really very pragmatic, especially around eligibility, recruitment, setting, and that sort of thing. A little less so on issues like organization and follow-up, or excuse me, and these flexibility dimensions. It is not purposely not pragmatic on follow-up. And that would mean this study did a whole lot of follow-up, much more frequently and intensively would have been done in usual care. Then going to the left, in contrast though, the primary outcome is something that would be easy to collect in usual care, that was really important to patients, that were easily understandable and provide feedback on. In contrast, I won't go over all the dimensions, but that you can see the study in blue dashed lines is much more of an explanatory trial. Although again, it's not totally explanatory because on issues like recruitment and the primary analysis, it was tended to be much more like usual care or generalizable. So again, this is something we encourage you to at least think about, and you can fairly succinctly, you need a little description in your grant, but present this figure and you can communicate a whole lot just with a simple figure. So let me summarize the first part of our session, or our focus today, on pragmatism, and then we'll turn to cost. So key bullet points here that I will read with some emphasis to think about when you're writing a grant is that you want to decide the dimensions on which you want to be more or less pragmatic. Second, think about the areas in which you want to be more, it's important to really nail this and to be comprehensive, costly, burdensome, make sure you exclude confounding factors, that sort of thing. Again, no study is or should be completely pragmatic or completely an efficacy or explanatory study. Second bullet point, it is important to realize that the general concept of pragmatism applies to both the research design as well as an intervention program, and we also should say implementation strategies. How pragmatic, how feasible, how real world are they? PRECIS, however, though, when you're using it, the PRECIS design is only, or planning tool, refers only to the design. So it's the issues there, as you can see, and we just summarized, the recruitment, supervision, measures, analyses. That is what you rate in PRECIS. PRECIS does not rate the intervention, and sometimes that's, people get tripped up there a little bit, although almost all of the same issues apply when you want to think about an intervention or the set of implementation strategies. So we recommend at least considering, not in every grant proposal, but thinking about reporting the PRECIS figure or another equivalent table or figure to communicate this. Some people feel that talking about the type of hybrid design, whether it's a type 1, 2, or 3 hybrid implementation effectiveness design, conveys much of this same information. But again, that'll be a good discussion. Lastly, and I say this for all aspects of a grant proposal, but maybe particularly for this one, is I like to say, show your work. And that is, in terms of deciding how pragmatic your study and your intervention and implementation strategies are going to be, demonstrate that you understand or recognize the pros and cons of doing this, and then briefly justify why you chose what you did, so that a reviewer doesn't think that you just were uninformed, you know, and just did this knee-jerk without thinking through the issues. Let's switch gears here. Take a breath. And now we're going to focus on cost and economic issues in dissemination and implementation research and grant proposals and publications. So first bullet point, this has gotten a little better over the last 5 to 10 years, but it's still the case that cost is one of the least frequently reported elements in almost all literature reviews or looking at grant proposals or other D&I work. In contrast, that's particularly a shame because this is often one of the very first and primary questions or concerns of potential adopting settings and decision makers. In fact, in some cases, functionally, if you start out, that's the first question asked, is what cost, usually meaning time and resources, is this going to take me to implement it? And if you can't give a good answer to that, functionally, the meeting may well be over. Very unlikely that you're going to be able to convince that new setting to adopt it. Third bullet point, when costs are reported, often this is not done this consistently, that people report on different elements using different measures, forget about some issues, don't report them according to guidelines that are there. And so you're really comparing apples to oranges if you want to talk about a couple different cognitive behavioral interventions, and people are using, they're both talking about cost, but they mean different things. Finally, and I'll illustrate this, different stakeholders. We always think about D&I as being multi-level and contextual, but different stakeholders have different perspectives on cost and different values and benefits. And we'll illustrate some of that, but that's a kind of a take-home point to keep in mind. So within REAIM, as well as most other approaches to costing, there's a few other kind of more nuanced issues are applying going down. Usually in implementation science, and certainly in REAIM, we consider the cost, assessing, understanding cost under implementation. And this would be both the intervention per se, if you will, core components or core functions, but also in particular implementation cost. If you read the Saldana article, this is the key emphasis or focus is on understanding the cost of delivery of the program. Usually what we want to do, and health economists recommend, focusing on these costs, but then subtracting out, if you will, the research cost. So for example, in doing a measure or evaluation assessment, you usually don't include the cost of like research assistance to administer a measure or to score it or whatever there. But you certainly would want to include the cost of delivering the program and all the staff costs that are involved, or it gets a little, here's an interesting one, if the measure is used to provide feedback on the intervention, and then that feedback is used, as in the PRECIS diagram, to further inform intervention, then at least part of that cost should be included, because that is a part of the program as it would be implemented regardless of whether it was research or not. A third point, not as universally done, but one thing that I recommend, and it was talked about in the Ritzwaller articles, if you had a chance to read that, is reporting replication costs. And what this means is taking what it cost in your particular study or project, but not stopping there, but then extrapolating this or estimating what would it cost a different type of setting under different conditions and contexts with a different staffing program with, for example, many programs involve electronic health records. So with a different or no electronic health record system, what would it cost them in these different settings? This is even more of an estimate than estimating cost in a given study, but we feel it's really important. And again, what the potential adopting setting really wants to know. Frankly, they could care very little about what it cost you in your research study, but they want to know what would it cost them. A bit of an issue that we can talk about in more detail, but should you include the cost of recruitment or promotion? My own bias is that you should, but not include things like informed consent, again, unless that would be done in usual care. But some people, not all researchers agree, and some people think the entire cost of recruitment or promotion of a program should not be included. More important, again, this notion of show your work is whether you're including that or excluding that as part of your cost is the key issue, just to be explicit about that. So let's think a little bit more broadly about what types of costs are important in D&I research. I have a few bullet points, but we'll talk a lot more about this. And again, there really isn't a right or a wrong answer, But the notion is, as with the PRECIS, think about which ones are the most relevant for your particular study, given the status of literature and given the purposes where you want to go. So usually in D&I research, you do want to focus at least on implementation cost. Usually this involves issues of how much time, what's the burden that's involved, and then what we call opportunity costs, which means that what other things do you give up? Usually settings and staff have limited time and effort. And if they're going to implement your program or policy or guideline, they're going to have to give up something else because they don't have unlimited time. So it is important to understand that. But it's usually this notion of time that is the key driver of implementation cost. Secondly, you might want to expand this then to take not only the costs that are involved, and you might expand this beyond implementation a bit too, to consider other types of issues, certainly like the setting resources, possibly do you need to rent or purchase additional space or not, that sort of thing. To turn into then cost effectiveness, where effectiveness you also combine the cost with often your primary outcome you have. So if it's smoking cessation study, what is the cost per one quit to get that? Or if it's a depression study, what's the cost to lower depression rate or a score 3 points? Some people expend this to another type of analysis, a quality or cost per quality adjusted life year, in an attempt to generalize this across. So you aren't mixing apples and oranges like in the two examples I gave, but both of those could be extrapolated to look at, to provide a more even evaluation criteria, quality adjusted life years. Even more challenging is the issue of cost benefit. So cost benefit then tries to monetize the effectiveness outcome so that you can make a purely economic case. So it would be the cost, saved or issues prevented there, like that might be focused on hospitalizations. And how many of those did you save and what were the cost of those, comparing it? You're going to see asterisks for the rest of the way down here. And the asterisk represents issues for which you probably really should have a health economist involved. It never hurts to have one if you can afford it in your budget, but particularly if you have a smaller grant, a R21, a R21, an R18, an R34, sorry, about getting that, but a initial more pilot level, often it may not be absolutely necessary if you're only looking at implementation cost and if you're using some established procedures there. Never hurts if you can afford it, but sometimes you can't. But if you're dealing with these other issues that we've talked about before, you almost definitely do want to include a health economist, or it's kind of the kiss of death, like having a really complex multi-level design with all sorts of missingness imputations, and you don't have a biostatistician. So in terms of thinking about reporting resources required or cost, how we do this, two key issues are involved here that I'd mentioned before. First one is to think about the perspective from different stakeholders, okay, including patients, because the issues are different, both the cost involved and kind of the values or perspective is important and varies across these stakeholders. So these are multi-level. And again, I put 4 here, but there could even be more levels than this. But you might think about going down from the broadest on down to the patient or recipient level there, thinking about the community or the entire complex health system, down to the particular intervention setting, like maybe that's a school or a work site or a primary care setting, down to the staff. What is it requiring from, and what's the perspective there of staff that are involved? And then finally, the recipients, patient or end users, what do they have to use? How much does it cost them? How much time? In general, for most implementation studies, and if it's not a primary outcome. I want to emphasize that. If it's not a primary outcome, often simpler is fine, or simple, as long as you are transparent and include the right thing. So again, I want to list some of the things there that you do want to think about reporting. And again, being transparent about what's included and what's not included. So I did mention a lot. I've been hammering on different perspectives. So this table just summarizes some of the key issues, and you can see both similarities and differences here across the patient and family perspective. What are they concerned about? Often transportation costs and like having to give up work time is the key issue. Clinicians or implementing staff then are often primarily focused on the time it costs them, but also other issues like materials or other IT issues that are involved, as well as opportunity cost. Adopting settings of different types, as you can see, are concerned about issues like developing the program there, the staffing, hiring and training, settings that are involved here. So that's pretty much it. I'm just going to summarize here, and then I'll look forward to discussing this with you in class. But key summary points are, in general, unless it's a primary aim, keep this simple. And we really want to focus on the field, as in the Saldana article. There's a number of new evolving things too, but on the issue of implementation cost, say, or possibly the cost of different staff. Second, think through the issues. We didn't have a chance to talk here about all the options for collecting cost data. That can be surveys, it can be observation data, it can be tracking, it can be most often interviews. But how to do this, who's going to do this, and when? Usually, health economists prefer to collect cost 3 times, or at least 2, but particularly like early on when intervention is just getting going, after the first few weeks, kind of midpoint, and then fairly later on in the project. We'll probably beat to death the multiple perspectives about whose cost. Next to last point is be familiar with, you have assignments to read some of the classic articles, but there are also others that were referenced there, or we'll talk about in the course for standardized reporting that you're doing, you're aware of those and following it. And then again, if there's anything complex, to kind of wrap up in the contrast to the first one, if you're doing more than implementation cost using kind of a standard template or guidance, it probably does make sense to include a health economist. So that's it for the presentation for today, and I'll look forward to talking with you in class and elaborating on some of these issues. Thanks.